Manoj sir. His topic is say no or is it easy in complex cases. And about sir, he is the most experienced cochlear implant surgeon, having done more than 800 implants, mainly the pediatric implants. He is a certified cochlear implant trainer, and he is having many clinics at Trivandrum, Cochin.
Stop. I'll introduce myself. One place, we have done almost 1,400 implants, and I don't operate in more than many places. Thank you. So, yeah, but thank you. I think we all know each other so well, so it's kind of superfluous to introduce each other. We know more secrets than you do. So, Bhanumati was very optimistic, and I wish I would have asked all the things here, you know. So thank you once again, Hyderabad. It's a pleasure to be here, and a pleasure to be among friends. You know, saying no, is it easy? You know, this is something that I face all the time. I'm not so happy as you are, Bhanumati. I'm not, certainly not. I get it. What happened? No, it's not happening. In this confused state, whether we should tell them, whether we should tell them whether they need to do implants or whether we should say no. And sometimes it's a tough ask. And coming from Kerala, it's an especially tough ask. Because people there are not very forgiving. I mean, they are. You know, they kind of distrust us most of the time. They're very questioning. And finally, it all boils down to, but you told us to do implants, so you did it, so, and we're not so happy, so what are you going to do about it? So which is something that I face all the time. So my audiologist especially, even when I say no, you know Shashi and Shabina, and you know what Shashi is, so he tends to say no even if I say yes. So it is. Yeah. Give me a minute. Is it okay? Apple is still all right. Okay. Now, we are all supposed to expect this. We want our children to be high performers. This guy is a karate black belt, so, and we want them to score very high marks, and we want them to get awards. But often we have to deal with something like this. You're a sinner. So this child, if they come to you and say that, give me an implant, I would do much better, you have to say no, right? And this is something that happens. So people actually expect much more out of CI program than what we say. This is one example about a case that we said no. See, there was this lady who was being deaf from 1988. She had some hearing. We did not know, like we did not know how much hearing she had till then. But till 1988, she had good hearing, and I mean that's what she said. And then she lost hearing. She became completely deaf since. And she came to us in 2010. She wanted an implant because she had married recently, had a child. Till then, she never felt that she needed to have hearing. But suddenly, she wanted to hear a child now. And then we initially said no. We said that difficult, for so much years of deprivation. And we actually did this story, and this is one of Banumati type stories which sorry for picking on you, but which are see, you know what happened here was, if she was a singer and she could sing any song that played to her till 1988, and any song that you play to her after 1988, she can't understand. It was very fascinating that it happened. So we at the time I really wish that I had not said no in the beginning. The trouble with people like this, they'll go tell everyone that Manoj will say no, but you go ahead and have an implant. So that's the trouble. But this sometimes happens. But look at so when we look at these things, we heard Rob say that if you want to normalize someone, you'll have to do them under 12 months of age. And till 2, you can get some kind of speech production. Intelligibility. But when they're over 6, this is what happens. They have auditory direction, they have possible improvements in speech production, continued dependence, but these are studies that come from the West where they have a support system that is better than ours. We have children who come to us 6 years old never having used a hearing aid, no speech at all, and not even having cued speech. They don't undergo any kind of rehabilitation, but then you have to say no, even at 6. This is something that we have to understand that. Now look at this scenario. This child, the older child, is profoundly deaf, is 12 years of age and has not had an implant. In fact, came to me when he was young, 1 year of age, went somewhere and had hearing aid use and did not continue until later, became deaf. Second child was normal, and God knows why they went for a third after all this. The third child, they found out hearing loss at 2 years of age, in spite of the first being deaf, fitted with a hearing aid, and then in the process of having a C evaluation at the center, found out to have corpus callosum agenesis. The child is hyperactive, has got low mental ability. This patient was been coming us, forcing us to support them for a government program. And I have to say no, or should I say yes? This happened 2 weeks back. Now, we know for sure that somebody with a corpus callosum agenesis is not going to do well. We know something that somebody who is hyper-irritable, who's low intellectual capability is not going to do well. Should I be pushing this into a government program where public money is going to be used for such a child? Or should we think that is the government program not meant for these children who are poor, where even spending some money is not going to be? So this is where dilemmas come in. Sometimes things are even more complex. This is, I did mention this in one of the last presentations. This is a 55-year-old male, had a right cochlear implant for bilateral profound hearing loss following cholesteatoma surgery earlier. He needed infection due to, explantation due to infections 10 years back. Had a bad legal battle. You know what, surgeon actually in a moment of anger wrote a letter saying that you cannot complain about your implant because you were implanted when the cavity was wet. Actually wrote this. And you were switched on when the cavity was wet. You were hearing when the cavity was wet. So there's no reason why you can't hear now. And the patient immediately went to court saying that it is said in the books that you should not be implanting on a wet cavity. And I got caught up in this angle. And because surgeon refused to explant, so I had to do explantation with the connivance of the company. And right now, what has happened is this. The patient's explanted cochlea is completely wiped out. It's gone, it's ossified. There is nothing in that cochlea. The left ear cochlea seems all right. But there is a cholesteatoma in the left ear. There are, both sides have been implanted, so this, in the left ear, there is a cholesteatoma, the blind sac area. Now, should I be implanting? The left ear is gone, the already implanted is gone. Right ear is implantable, the non-implantable, left ear is staging. And there is a long period of auditory deprivation this year. So this 55 years old now, first surgery he went deaf when he was 28 years old. This legal battle going on. I don't want to be the third entity in the legal battle. But we have to do something. So these are answers that he cannot answer. Mon, would you implant this left ear or not? I send him to you. Now look at what happened, this one. So this child was implanted 6 years back. And if you can see from the film that the implant is only in the basal term. The operation notes clearly mentioned that NRT was available from electrodes 11 to 22. And this is the ECAM pre-implant, what I did recently. So you can clearly make out that there are electrodes till 1 to 10 are inside. The impedance measurements are normal. Beyond is really high, so it's probably outside. It was unfortunately mapped for the entire electrode. It was mapped for this. So 6 years the child went on because the child had residual hearing in the other ear. So was aided with the hearing aid in the other ear. It was a biomodal implant. The child kept on getting, 2 years to 6 years, and then the good ear, the left ear deteriorated, and then the child found it really difficult to manage in school. Comes to us because the surgeon told them that it is migrated, so we need an implant from the funding agency, the backup. The contract between the government and the funding agency do not allow backups for migration in the rule book. They allow backups for infections, not for migration. That's a contract. So the company looked at the contract book and said, it's migrate, so we can't give you a backup. Now surgeon is refusing to touch because there is a backup. So it comes to us. Now what should I do? That's what. So no, he is refusing to go in because he thinks he will damage the electrode, so he will go in only with a backup. Now my question is that, would I get reasonable responses if I put it back in, the whole thing, or should I remap the electrode for the basal tone only? So Shashi actually took the ECV out, told me that you go in. So that's what we did. So we had to dissect out the electrode leads, and you can clearly see how the stiffening rings are outside nearly outside the mastoid. But the round window was luckily full open, and after a bit of a struggle, re-implanted, and we got good response across all that, and we can see that the ECAPs right up to 3 and 1 and 2 are normal. The surgeons, previous surgeon, saying no to re-exploration was not right. Not right. So this is an thing for all the surgeons, young surgeons here, that if you don't get NRT. See, when I go around, people say that NRT is nothing, ART is nothing, NRI is nothing. It's okay. I am a good surgeon, I put it in, so it should be alright. So every NRI that you don't get needs to be investigated. We have had situations where good surgeons have put an implant into the vestibule and did not know it till they went to another country to have a scan. That was terrible. So this can happen. Like Gunesh was telling me yesterday, he is still worried whether I put yesterday's implant to vestibule. So I am. Because it's quite possible with the gusher it can shift and go in some inside. So I was telling Jaswinder that we need an X-ray today, and I really need to know, because if you don't get an RI, I really was upset yesterday because we got nothing. So when you don't get an RI, there's something that is wrong. So if you don't get an RI, please ask for help, do a second imaging, and do something corrective at the earliest, because correcting something like this 6 years later is really, really tough. Correcting it 5 days later is going to be really much easier. Now look at this one. Patient has got anomalous ears, both sides. One is worse, the left side. But when we did the scans, this is what we get. So you get a sloping loss on the right side, and you get a profound loss in the more anomalous ear. And we get the SRT, SDC discrimination at 35 dB in the right ear and 85 dB in the left. There is a possible history of post-meningitis sequelae, and should we implant this patient or not? Because the child is having poor speech, do you think it's a post-meningitis equivalent, or is the sloping loss here better? And would you at this time be implanting the right ear because it is lesser anomalous, or should you go and implant the left ear?
Left ear.
Left ear. So that's what we did actually, but again, it wasn't so good. Now coming to the last scenario, there is this patient who was born with a complex cardiac defect. He had a dextroposition heart, he had transposition of great arteries, single ventricle, severe infundibular and pulmonary valvular pulmonary stenosis, had a conoventricular ventricular septal defect. I really don't know what it means. And there was a patent foramen ovale. And this was like this. It was much worse than a phallospectrology. And he underwent a procedure called bidirectional Glenn with PA banding. It was a bit of a complex procedure. Now, children with this particular anomaly tend to have CS of pressure that is increased, and they can have an enlarged vestibular aqueduct. So it is recommended that any child that has got this particular anomaly needs to have scanning early, because they may have progressive loss which somebody may not even realize. So we saw this, and there was ventricular septal defect and white vestibular aqueduct, otherwise normal cochlear nerves. And child had, in spite of the fact that all this had happened, had really good speech, because the mother actually could not concentrate on habilitation and hearing aid. But it's possible that child was not probably deaf when they were born. And the procedure itself accelerated the deafness, because when you do the banding, the pressure, CSF pressure increases, and that can cause a side effect on the cochlea, and became deaf. So we did implant him and got good.
So was there a gusher when you did the implant?
There was, not so much, not like this.
Because I think we're a bit cautious about interpreting CSF pressure changes and things. If you truly got a gusher, then sure, the CSF pressure affects the cochlea.
There was a gusher, it was definitely leaking, but not very quickly. But see, the mother's history is like the child was born and they didn't suspect anything, obviously did not do any hearing screening. As the cardiac evaluation was going on, they realized that there was deafness, had audiologic evaluation but no imaging. The surgery happened, and there was a long period of habilitation because of complex cardiac effect. When the child came out of the ICU, the mother started blaming the hospital that something you did, and the child became deaf.
But that history is fairly characteristic for large vestibular aqueduct syndrome. It may have nothing to do
with the cardiac.
And with all of these cases you present, the most important thing is understanding and realistic expectations. And what we have to concentrate on educating the families about is realistic expectations. And it's on that basis that we make decisions for or against something.
Yes, sir. Now, what actually happened was really tragic. The child died. No, we actually talked with the cardiologist. He said that the child has got a good life expectancy, but there has to be a second, less complicated surgical procedure for the heart after.
See, this is really the issue. I think many of these complex cardiac cases, they don't survive beyond a year.
We had an extensive discussion with the cardiologist, and then we talked to them, and they said that you should actually have an surgery, because the child is supposed to live reasonably long. So they had the second surgery, which was supposed to be less complex than the first cardiac surgery, had an intra-surgical event and died. And I was really upset. One, because it is not always easy to lose a cochlear implant patient, because I like your family. But what if the parents are very angry at what you have done?
It's a very, I think it's probably a very mean thing to say, but I've had 2 or 3 of these very complex cardiac, children. They've had multiple kind of procedures and they come to you. So what I do is I give them a good 6 months. I try to sort of put them through habilitation, do this, do that. Buy some 6 months time to see how they are stable. Because you're going to put them through an anesthetic procedure, and if there's anything on the table, it's going to be on you. So the 6 month you buy sort of tells you whether this child, how active is this child, how is it running around, is it playing with blue, is it fine. If the child is running around fit, active kid, really, going places, that child is.
He was very active.
Yeah, and that child will probably take.
So would you have implanted him? Knowing this?
Oh, absolutely. We would definitely, and as I said, this is characteristic for large vestibular aqueduct syndrome. So the prognosis from a hearing point of view with a cochlear implant is excellent. And so we have to be advised by the cardiothoracic surgeons and cardiologists whether it's safe to do a cochlear implant. And then the parents have to understand that if we're trying to improve the hearing, there may be risks and there may be mortality associated with that. But that's not our decision so much. It's the family and the cardiologist's decisions. And so, I would not expect the parents to be disappointed with you.
Yeah.
They weren't. They
They should be
actually sent me
disappointed
a,
with a cardiothoracic surgeon who killed the child. So it's not your fault.
they actually sent me a letter last year saying that this is the first anniversary, some year anniversary of you giving back hearing to our son for a year.
That's what
It made me actually cry.
But Manoj, can I ask you what kind of counseling did you do as a clinic? Sorry. Do you mind if I ask you
Yeah.
what kind of counseling did you do as a clinic
For in general or this patient?
for this child?
No, this patient went through a lot of counseling. In fact,
Specifically like what?
we told them that, see, like Rob said, I really expected a good outcome because it was, to my mind, something like LVAS, which generally does well. But we were not concerned about the hearing and the part of it because we knew the child would do well with the CI. The counseling was regarding the cardiac. Because it was never to do with this hearing part. So we actually made the pediatric cardiologist sit with me and then we talked. So the pediatric cardiologist I knew. The cardiac surgery happened elsewhere. So this patient was in my city. The pediatric cardiologist was in my city in another hospital. The cardiac surgeon was in another city.
So why
So-
was the anger directed at you then?
I said I thought. There was no anger. I thought.
Oh, it wasn't.
Yeah, it was prepared, but it wasn't so.
It wasn't so. They were not angry. I was, see, when the death happened, and when the second surgery was going on, they came to me. They said the second surgery was posted, and then I called the cardiac surgeon again. And he said that, this is much more simpler. That the child can have the first procedure, which took them 6 hours, and the implant that took them an hour and a half. The second procedure was supposed to take 45 minutes. They had to do some stenting or something, which was not very common. But and I told them that was my fear. I told them, it's okay. So that is where probably my counseling went wrong, but in a sense that I told them that it's okay. You can go for the third surgery, he'll go fine. But by then the child had really improved. Speech and hearing, was running around playing, had no cyanosis.
Manoj, we also had a similar experience with a child who actually had a atrioventicular dissociation, AV dissociation. The cardiologist told us that you have to pace the child and then only take up the patient for cochlear implantation. You've got to be very careful with your monopolar cautery. Even the bipolar settings have to be very low so that only when it's actually required you have to do it, otherwise try to avoid cautery. And then you do the implantation. Similarly, I do not know if a cardiologist had done all the evaluations.
Yeah, they did.
That say he underwent one procedure and then we did a cochlear implantation. If we did use monopolar cautery and other things, which could have, suppose these have definitely these children have some amount of arrhythmias after having undergone.
No, the procedures for all these patients, we operated on people with German Langnese and with methemoglobinemia and complex cardiac arrest. I have got a big series of people, but luckily for me, nothing happened with the surgery, but this happened during the second cardiac procedure. So I think it is difficult to say no, because sometimes you are torn between the parents' need for hearing and what you can give. And sometimes some parents come and tell you that the little that I've got is something a great blessing. Some people would say that we expected more and your counseling made us think, but even if you have written down in paper. But even if the proportion of patients who complain to you are a small proportion, they still cause you a lot of pain. I think they are about 5 to 10% who, in spite of all the counseling that you do, eventually come and blame you. And that causes a great deal of pain, more than the happiness the remaining 90% gives you. That's my way of looking at it. I really feel bad about it. So we can't really predict how these children do well. The entire team has to take responsibility. Say, for example, if the audiologist is not getting good NRI values, he has to talk to the surgeon, and a surgeon has to understand that he, as a ostensible leader of the team, has to understand the first responsibility is to understand, is my implant is in place, instead of blaming somebody else for not getting a crystal integrity test right, which is very wrong. So you have to understand what you can do. In fact, there is some procedure that you cannot do. You should actually ask for help. You know the help that I got yesterday from everybody here, because it is important that in a tough situation you really need to ask around, and you have to you have to be very careful before you say yes to these doubtful cases. You have to say it after a great deal of thought. But if you have to say no, say it with conviction. But before you say no, ask around. Is it okay to say no? I would definitely call up and call someone and ask to say. And like Rob said, it's very, very important to have good counseling skills, because counseling is the key. Because whatever matters, if you are dealing with cases like this, the story that you heard about a girl with a complex anomaly with 8 throats and doing well is a flash in the pan one. I would not go by it. I would seriously not go by it, because if that has happened, you are extremely lucky. And I don't think when I will get that lucky next. I have not got lucky so far. I have been very disappointed with all the anomalies that I have got. It makes you sad. It makes you sad 10, 15 years later when you look back and say that, this is not how I wanted my child to speak. But yet, this is just a word of caution. I am a person like this by nature. Me and Neil are the biggest mood depressors in the country. But I think it is time that you look at these stories also, because it is easy to say yes, and sometimes difficult to say no. But you have to do it at times. Thank you.